Hi guys, so let us quickly finish our the patient that I saw that we spoke about on part 1. A patient with hyperkalemia, 61-year-old male patient with hypertension, diabetes, and we said that the hyperkalemia was 6.2, and we also said that he had a sodium of 108, hyponatremia, had a potassium of 6.2, GFR of more than 60, a creat of 88, and urea of 7.2. So like I said, when this patient came like this, I wanted to find out. So we said that this patient, we labeled him as having persistent, so the diagnosis is persistent hyperkalemia, and we said that he was not having hyperkalemic emergency because the criteria for hyperkalemic emergency, as we know, is someone who's got symptoms like weakness of maybe the legs or the arms or the neck or the trunk, ECG changes, or someone who's got who has a there's a bit of a gray area here. I will show you why. So someone who's got a potassium of 6, whether they are symptomatic or not symptomatic, ne? And someone who's got ECG changes. My patient had 6.2, ne? But no ECG changes. Clinically, the patient looked well. So, so what I wanted to get to, I wanted to find out why was this patient having persistent hyperkalemia. So the first thing that I looked at is the UNEs. The UNEs looked normal, so which means this patient did not have renal impairment. So it means this patient was able to chemoregulate and also to osmoregulate because the kidneys are functioning. So it was not a matter of the kidneys not being able to excrete the potassium. So the next thing that I looked at his treatment. So he was taking enalapril 10 milligrams per hour daily. He was also on aldactone or spironolactone 25 milligrams per hour daily. He was also taking simvastatin 150 milligrams. He was also taking, this is very interesting, eh? He was also taking simvastatin 10 milligrams daily. He was taking metformin 1 gram for the diabetes per OSPD. So those were his drugs. So when I looked at his drugs, when I tried to analyze, I found that he had 3 drugs that had a potential to cause hyperkalemia. The first one was the ACE inhibitor, which in his case is the enalapril. We've spoken about ACE inhibitors causing hyperkalemia. ACE inhibitors are known to cause hyperkalemia. And if you look at the guidelines, they even say that if you give a patient a loop diuretic, you don't have to supplement them with potassium if they are on an ACE inhibitors, because the ACE inhibitors on their own, they do raise potassium. So that's that. Number 2, so basically if you give a patient Lasix and you combine Lasix with any of the ACE inhibitors, no need to give that patient potassium supplement like potassium chloride. And also, if you give a patient a loop diuretic and you give them aldactone, you don't have to supplement them because the aldactone will cause the hyperkalemia. So my patient was on aldactone, which is known to increase, it's a potassium sparing diuretic, so we know. So these two, the third one was there was the NSAID there, the Disprin. I know that we hardly speak about because yes, it's cardioprotective, it reduces the heart, or it reduces the chances of having heart attacks and CVA, all those things. But the fact remains, it's an NSAID. So, and NSAIDs are known to give a patient renal problems. They are also have got a potential of increasing causing hyperkalemia as well. So what we needed to do, there was no way we were gonna so what we needed to do is to make a pre-treatment plan for this patient that is specific for him. So I went to discuss this patient with the on-call doctor for internal medicine. The approach, we thought that we don't really need to IV therapy this patient. We don't need to shift this patient again because he was shifted last week. And so now we needed to, remember, when you manage hyperkalemia, if you can go and watch those videos, when you manage hyperkalemia, you've got modalities, treatment modalities that cause shifting of the potassium, like IV therapy, your calcium gluconate, your insulin, your dextrose, your beta 2 agonist, so things like that. Yeah. So those that's so you've got that IV therapy, and then you've got those beta agonist. Those are for shifting. But then now, what do you do to take the potassium out of the body? Because what you need to take the potassium out of the body, and we mentioned that the treatment options there is giving a patient loop diuretics because they are potassium wasting. Number two, you can give them gastrointestinal cation exchangers like Kayexalate. You can also dialyze the patient, hemodialysis. Those are the methods of taking now the potassium out of the body. So we thought that let's leave this and rather manage this patient as a non-hyperkalemic emergency patient because it was asymptomatic. Yes, the hyperkalemia was more than 6, but it was just 6.2. So so I want to show you what did we do for this patient. So what we did for this patient, so I discussed with the internal medicine. So what we did is, for the enalapril, we reduced the enalapril to 5 milligrams per ounce daily, and then we stopped the aldactone. So we don't really know why this patient was given those two drugs. We don't know if, because we know most of the times our first line drug of choice for antihypertensive is diuretics, and preferably loop thiazide diuretics like indapamide or hydrochlorothiazide. But this patient was not on that, and it's sort of like a recombination of drugs, giving a patient aldactone without loop diuretics or even a thiazide diuretic, just going for that kind of a diuretic. So we don't really know the reason behind. So we decided to stop the aldactone altogether and give the patient Lasix 40 milligrams daily. And we also gave the patient Kayexalate, which is a cation exchanger, cation exchanger, Kayexalate. And also, so we continued with the aspirin, continued with the metformin, continued with the simvastatin. So And also we gave this patient, started on amlodipine. Since we decreased the enalapril, so we started this patient on amlodipine 5 milligrams daily for 2 weeks. So this patient is going to be on this treatment for 2 weeks. 2 days before he comes, he's going to go and do UNEs at his local clinic and then come with the results. We're going to check the results on the system. That's what we did for him. So if you can pay attention to this treatment, is that we have eliminated one big cause of hyperkalemia, which is aldactone. Eliminated that one, taken it out. And also we have reduced the ACE inhibitors, which is also a very big cause of hyperkalemia. And then now what we did, we gave 2 drugs that will take the potassium out of the system. Lasix does that very well. As much as we are giving Lasix to control the blood pressure as a form of a diuretic, and also so as a form of a diuretic to control the blood pressure, but also we know that Lasix is going to take out that potassium as well. And then the Kayexalate, we gave 15 grams per os BD for 3 days. Kayexalate is a wonderful drug. I had a patient with hyperkalemia back then who had renal failure. Gave Kayexalate for 1 day, and then bam, the following day when I took the UNEs, the potassium had corrected, but it was very high when I saw the patient. It was 7 point something. So it's a very good drug. So for 3 days, that one. And then now, another thing that I did, so now we needed to do something about the hyponatremia. So I gave normal saline 1000 mils IV, which we ran over 3 hours. And so that's when I left the patient. So I'm sure the doctor that took over did UNEs again, or an RNA. Unfortunately, we don't have an ABG, so to check if it has corrected. So that's that. So another thing that I did, I was like, okay, we've got a patient who's got 3 risk factors for ischemic heart disease. So this guy has 3 risk factors for ischemic heart disease. One of them is hypertension, the diabetes, and the fact that he's on this, I assume that he's got some kind of dyslipidemia. So he's got 3 risk factors for ischemic heart disease. So what I did, I wanted to look at his heart, what is happening with his heart. So I decided to take bloods for pro-BNP, and then I took CK, MB, and I also took TROPS. The ECG, like I said, it was normal. So why did I do these bloods? So the reason why I did these bloods is because, remember, when you've got a cardiomyocyte, when a patient is developing heart failure, the cardiomyocytes, they keep stretching and stretching and stretching and stretching. And as they stretch, they secrete BNP, which is a brain natriuretic peptide. So they secrete this hormone. And as they secrete this hormone, so this is like a silent measure of if you're trying to check if the patient is developing CCF or not. Remember, you can have heart failure that is still subclinical, that is still not symptomatic, and that will be a patient. If you've got heart failure but you are asymptomatic, it means you are a class 1 in terms of the New York Heart Association, the classification of heart failure. So I wanted to check if he's having excessive amount of BNP in his blood. And the BNP, if it's more than 300, then you have a diagnosis. You are having a patient that is having heart failure. So I did. So we're gonna, when he comes back, we're gonna look at these results. I think I will trace these results and give you feedback, guys. So if you've got a patient, by the time a patient has got swollen legs, they've got orthopnea, or they are very symptomatic at that time, they are already a class 3 or class 4 heart failure. You want to pick them up earlier. So it's like I use this like sort of like a screening to see if the patient's got heart failure. Remember, you can have heart failure without cardiomegaly. Yes, you can. So this one is very good at picking up an early onset. So yeah. And why did I do CKMB and TROPS? So the reason why I did that, like I said, this patient's got a risk of ischemic disease because of these three things. So like we explained that troponins are your acute markers for myocardial infarction. So if you've got an MI today, you will use your troponins to pick it up. But an MI that happened last week, you cannot pick it up with the troponins, but you can pick it up with CKMB, because like I explained, please go and watch a video, approach to a chest pain. So if you've got MI, your troponins, they take a few hours to go up and take a few hours to go down. So they go up very fast and go down very fast. So their concentration in the blood. But CKMB takes a couple of days to go up and takes a couple of weeks to go down. So in MI of last week, you can pick it up with a CKMB, but not the troponin. So that's why I always do this too. So that's what happened with this patient, guys. I hope we learned something. I hope you enjoyed that. Please feel free to comment, like, share. Please feel free to comment, and maybe if you've got a way of, maybe you think that you could have managed this patient different from what we did, you are more than welcome to let us know, so that we can all of us learn. Thank you so much. I hope you enjoyed that. Let me take rest now before they call me. Okay, thank you. Bye.